Once again, good evening and a very warm welcome to our webinar on hip and knee replacement surgery. My name is Louise and I'm hosting tonight's session. Firstly, I hope we haven't interrupted your plans to view the solar eclipse this evening. Hopefully there's still time for you to head outside afterwards and enjoy it safely. I'm delighted to be joined by expert speaker, Mr. Raman Thakur, consultant orthopaedic surgeon at Bendon Hospital. Tonight's session will begin with a presentation from Mr. Thakur, followed by a live Q&A session. If you have questions at any point, please feel free to submit them using your Q&A icon at the bottom of your screen. You're welcome to ask these anonymously or include your name. But just a quick note that this session is being recorded, so any names shared may be visible in the recording. To help us get through as many questions as possible, please do keep the questions brief. If you're interested in booking a consultation, we'll share all the relevant contact details at the end of the session. I'll now hand over to Mr. Thakur. Thank you.
Good evening, everyone. Thank you, Louise, for having me here. I'm going to talk about hip and knee osteoarthritis and replacement surgery. As you are aware, my name is Raman Thakur. I'm an orthopedic surgeon, having trained back home in India and subsequently trained in Southeast under the training program at St. Thomas's and Guy's Hospital. I subsequently did a fellowship in hip and knee reconstruction in New York at Lenox Hill and Hospital for Special Surgery. I worked in Bennington as a consultant since 2012. And my interests include hip and knee replacement, arthroscopy, and ACL reconstruction. In this webinar, we are going to cover briefly the topics of consultation, assessment, brief note about osteoarthritis of the knee and the hip, what are our treatment options, conservative, operative, and non-operative, and the risks from operative intervention, hospital stay and recovery, and how you can use certain tools to help make that decision. And finally, the more important question and answer session. So, if you have ongoing symptoms of persistent pain in your hip and knee, and which is becoming more intrusive, affecting your ability to do things, then it would be important to get that checked out. It would be in the initial consultation, the history and symptoms are reviewed. We check out the stability and movement of the joint and muscle strength, and subsequent discussion about investigations would be X-ray or a scan if required, and then we can discuss suitable treatment options. So talking first about knee arthritis, what is osteoarthritis? Osteoarthritis is predominantly a wear and tear related arthritis, as opposed to rheumatoid arthritis, which is more systemic illness and affects multiple joints in the body. It presents with early morning stiffness and also pain with activity. It can have waxing and waning episodes with intermittent exacerbations, and gradually with increasing trouble affects the ability to walk distances. The knee can swell, sometimes it can lock or give way, and in the longer term it can present with deformity and pain at rest. As mentioned, the predominant pathology is wear and tear of the articular cartilage, with the underlying bone getting exposed and causing more damage and ongoing pain and stiffness. So just a picture showing a healthy joint on the left with good articular cartilage covering the ends of the bones, and on the right side, gradually wearing of the cartilage and then subsequent exposure of the subchondral bone. We mentioned about treatment options, and always we talk about non-surgical options. And when we are talking about non-surgical option in either hip or knee, it is similar. First would be to reduce stresses across the joint. Having a good body weight would certainly be beneficial. Modifying activities where kneeling, squatting, and things like that may aggravate the pain. Again, trying to reduce those sort of activities and modifying and reducing that activities. Physiotherapy to help strengthening of the muscles, sometimes use of braces or strapping. And if simple analgesics aren't helping, then certainly looking to options of intraarticular injections. We do 3 types of injections at Benenden. One is a steroid injection. The second one is a lubricant or hyaluronic acid injection. And the third one is an arthrosomate injection, which is available as a self-pay treatment. In the surgical options, there is both arthroplasty or non-arthroplasty options, and we can look at option of arthroscopy with patients who have got mechanical symptoms and loose cartilage or meniscal tears that can be addressed through an arthroscopy. Sometimes, if it is a small area of damaged, exposed bone, a microfracture can be performed to help heal up that area and allow people to continue performing activities to a reasonable level. If there is a significant deformity of the leg, that can be corrected with an osteotomy. Cartilage transplantation is an option in a small proportion of people, and that is done at specialized units. And finally, if that is not suitable for joint preserving options, then either a partial or total knee replacement. As mentioned about the outpatient injections, we talked about local anesthetic and steroid, which is at the bottom. Outpatient procedure may delay knee replacement surgery for at least 6 months. All the caveats with any injection is that there is a downtime. So if people consider an injection, we would recommend not having a knee replacement for 6 months afterwards. Durolane, which is the hyaluronic acid, is again done as a single outpatient injection. It replaces the normal hyaluronic acid in the joint, which is affected and poorer quality in arthritic knee. It helps lubricate the joint. It helps reduce inflammation and swelling, and can be effective for pain relief beyond 6 months. The company would not recommend repeating a repeat injection at least 6 months following the previous injection. Finally, arthrosomate is a self-pay treatment. It is a gel which goes into the lining of the joint and then helps reduce the inflammation and cushion and acts as slightly flexibility, improve the flexibility of the joint. And I would like to clarify that it is not actually a cushion. It doesn't actually go between the bones. It does not work in that way. So where it says cushion, it is more to cushioning the lining of the joint rather than actually lining between the bone on bone situation. The results are variable. Studies from Europe suggest that the effects may be lasting about 5 years. Independent studies are happening in UK, and we are still awaiting the outcome of their results to confirm that the effects are as long-lasting as mentioned in the European studies. Knee replacement surgery, over 100,000 performed in UK in 2024. It is still the gold standard in end-stage osteoarthritis when conservative treatment has not been effective. Average age is in the late 60s, and just over half the patients are female populations. The prosthesis we use is a Vanguard knee replacement manufactured by Zimmer Biomet. It has got an ODEP rating of 15A, which is one of the highest rated implants, and 10-year survivorship of these is beyond over 96%. We use the cemented option, where we use bone cement as grout to fix the implants, and in most of us, if there is damage to the kneecap, we would replace the kneecap as well. Partial knee replacement is possible in patients who have got limited arthritis affecting only one part of the joint, either the inner or the outer side, or some, in very small proportion of patients, the kneecap joint, patellofemoral arthritis. A damaged compartment is replaced with the prosthesis, leaving behind the healthy bone and cartilage. And in general, patients tend to recover a bit quicker than a total knee replacement. We also have the option of performing knee replacement surgery with robot assistance. This is the ROSA system, which is used with the Vanguard knee replacement. It helps balance the knee soft tissues better, and therefore less dissection and less cutting. It also stops us needing to open up the bone, and therefore reduce bleeding and reduce inflammation. Usually helps in the early phase of recovery, making it a bit quicker. There are sensors attached to the leg through a couple of pins, so there is a small extra incision needed for the robotic placement of the sensors, so that the robot can then guide the surgeon, because the robotic arm moves with the leg, and therefore it helps automatically adjust based on the position of the leg during the surgery, and can be used either for a partial or total knee replacement. Moving on to the hip. Hip osteoarthritis, you find symptoms are pretty much similar. Pain in the knee is predominantly around the knee. Sometimes hip pain is felt in the groin, on the side of the hip, or in the buttock region. And occasionally I've had patients who have come with a painful knee, and when we investigated them, they had quite severe arthritis in the hip, which was presenting as a painful knee. It affects ability to perform day-to-day tasks. Mobility becomes very restricted. Patients have sometimes a perpetual limp, and sometimes the hip can give way. Again, age-related wear and tear. Weight, again, can be a big issue with either arthritis in the hip or knee. It may be the precursor, particularly in the knee, but it also aggravates and hastens the progression of arthritis if people already have some injury or similar problem. Then if the arthritis sets in and people are overweight, then it can speed up the progression of arthritis in the joint. Similar appearance with a healthy hip on the left and bone-on-bone arthritis on the right picture. Non-surgical options, again, are manage the pain with simple analgesic anti-inflammatories, lifestyle modifications, and use of crutch or cane to help walking might ease pressure on the other joints and make it more comfortable. Sometimes insoles can help. physiotherapy to help improve range of movement, sometimes with either Pilates or stretching exercises and steroid injection if the simple analgesics and physiotherapy aren't sufficient or people are relying on too much oral medication. Surgical options are hip replacement. Hip resurfacing is still not as frequent as it was in the past. There have been quite a lot of issues with metal on metal. Newer prostheses are coming into the market and are still experimental with resurfacing. Obviously, if hip fusion is an option, usually left at the last stage and has fallen out of favor in recent years. Hip replacement surgery, hip prosthesis is made up of the ball is removed. The prosthesis comprises of a pin which goes into the femur or a stem with a ceramic ball on the top, a shell with a plastic liner which goes into the pelvis. And the movement happens between the ceramic head and the plastic liner, and in that way, the bone is not rubbing on bone and the arthritic pain is relieved. It helps also improve range of movement, and as the pain is gone and people rehab, their walking becomes pretty much normal. As mentioned, the prosthesis on the right is a titanium prosthesis with ceramic ball and a ceramic liner on that picture, but generally the modern plastics are as good and cause less of an issue, and therefore nowadays the choice is ceramic on plastic. The left picture is that of a cemented hip, where the material has to be usually cobalt chrome, a bit stronger material, and the ball can be either ceramic or metal, doesn't matter. That would usually reserve for people who have got slightly poorer bone stocks and more significant osteoporosis. Otherwise, the uncemented replacement is usually the method of choice with most of my colleagues. So risks of joint replacement, whether it is hip or knee, it is similar. Injury to tissues around the nerves, the blood vessels, the tendon, and the bone. We are worried about, and we take precautions to limit damage. During recovery, we are concerned about wound problems, bleeding, infection, blood clots in the leg, clots going to lungs. We give blood thinning medication to reduce the risk of blood clots. Limping because of stiffness, because of pain, and recovery, weakness of the muscle, which gradually improves with time. Stiffness and swelling, again, will improve with time. We are concerned about risk of dislocation. Hence, there will be some do's and don'ts, which will be reiterated by the physiotherapists to reduce risk of dislocation. Long term, it may become loose or wear out and may need revision surgery. So, in general, the journey starts with attendance at pre-assessment, making sure all your bloods and other medical conditions are optimized, and then once the date for surgery is fixed, you're admitted usually on the same day surgery, and usually are in hospital 1 or 2 nights. And if the surgery is in the morning, usually patients are got up on the same day. If the surgery is afternoon or late evening, then mobility is usually the following day. There may be some discomfort and swelling, which is helped by elevating the leg and using analgesics. Physiotherapies help progress your mobility of the patients and get them going. And usually patients are discharged when they are safe on their feet, have mobilized independently, and have done stairs. progress with mobility at home, and most people discard their walking aids by 4 to 6 weeks after surgery. So, as mentioned, early recovery phase, in the first 2 weeks, there may be bruising, swelling of the thing. Usually the wounds are checked by the practice nurse, and provided they are healing satisfactorily, continue with simple analgesics and ongoing physiotherapy. If everything is progressing as planned, then most people are able to return to driving at 6 weeks, and at the same time, there will be a follow-up appointment with most of my colleagues. 3 to 6 months, recovery goes up to 90%, and most people start getting back to normal activities by 3 months. Any excessive activity, rotations, sports, golf may be a bit longer, and usually up to 6 months after surgery. Some of my colleagues, 5 of us, do hip and knee arthroplasty, and then a couple of my other colleagues who are only knee surgeons. And this is a team, orthopedic surgical team at Benetton. There, to help you decide, certainly patient decision support tools are there. You can look up on the private healthcare information network about consultants, about the hospital performance, and also the National Joint Registry is another resource where you can get similar information, including the NHS data and reviews on clinicians at certain websites such as Doctify. So National Joint Registry data, most recent is the 2024 hip replacements until March 2024. From April 2003, 116,900 joint replacements a year. 60% are female population, and average age is slightly in late 60s in both groups. Majority of the hip replacement surgery is for osteoarthritis with acute trauma. In neck or femur fractures, about 4%. With regards to knee replacements, again, over 134,000 primary replacement procedures, slightly higher proportion again of ladies compared to men. 98% of surgeries are for osteoarthritis, and 15% of procedures are partial knee replacements. Average BMI in both groups is around 28 to 30. So,
okay. So thank you very much for running through those slides and explaining the treatments for both conditions. We're really pleased to have lots of you with us today. So we have quite a few questions. We'll do our best to cover them off. And if some are repeated, then like are very similar, I'll try to combine them just so you know, and we'll cover as many as we can. Also on this slide, you'll find some information about arranging a treatment. So our first question is, what is the difference and benefits between the hydronic or arthrosamid injections? So the different types of injections, and does it depend on the knee condition?
So both the arthrosamid and hyaluronic acid have different mechanism of action. It is probably a bit more effective if the arthritis is not bone on bone, but it can be used even in that situation if patients are somebody who can't have a joint replacement or knee replacement, or somebody who doesn't want to have a knee replacement, because when it is bone on bone, that would be the first choice of recommendation to have go ahead and have a replacement surgery, because as you can see, it has got a long track record with good outcomes. And if it works, it has got good long-term solution for patients. So as I mentioned earlier, and I will repeat it so that people have that clarity in their mind, the hyaluronic acid is a natural lubricant in the joint, and it replenishes this hyaluronic acid, which is normally a bit defective in osteoarthritis. It is not as good as a normal knee lubrication. So therefore, putting in hyaluronic acid, which is more normal, certainly helps ease the lubrication, helps more better mobility, and also helps by reducing inflammation and also pain relief. So those are the sort of benefits that hyaluronic acid can give. It can last 6 months. Sometimes it can last a bit longer. And they can be repeated if patients want to have it repeated down the line after 6 months. Arthrosamid works differently. It reduces the inflammation in the joint. Inflammation is a big component of pain producing pathway in an arthritic joint. What it can't do in most patients is take away the bone-on-bone pain. And we do not know how much of pain patients get is from inflammation or how much is from bone-on-bone situation. But having done this in patients who didn't want joint replacements, about 70% of patients, even with a bit of advanced arthritis, if they do not want to have a joint replacement, they seem to benefit from having had an arthrosamid injection. The swelling goes down, the knee becomes more supple, and the pain eases off. So it can be variable. It may not give 100% relief of symptoms, but if it can give a meaningful relief of symptoms, and it can give a durable relief of symptoms, we are still waiting to see that independent research will show what the company and in the initial research suggests that it is much longer term, and we are still away. The jury is out on that.
Mm-hmm. Thank you. How soon after spinal fusion and decompression surgery can I have hip replacement? Angela asks. She had back surgery 3 months ago.
So my advice would be to speak with your spinal surgeon. Most people can have a hip replacement surgery 3 months after their spinal surgery, unless the surgeon feels that it is too soon and they want you to wait, then that is fine. But if they are happy for you to go ahead and have your other joints sorted, then please go ahead, book in a consultation, and we can assess whether that is the appropriate pathway for you.
Thank you. Felicity says, when can I start bending more than 90 degrees after a total hip replacement? And is there an alternative position to sleeping on her back after a total hip replacement?
So in most people and most of my colleagues operate from a posterior approach. And when we do that, that is when we don't want people to bend their knees beyond 90 degrees. As I said, the only thing holding your hip replacement in place are the sutures we use at the time of surgery. We don't want the leg to go into positions that might stretch that sutures or damage the sutures, and that can sometimes make the hip unstable and cause a dislocation. So that's the reason why most surgeons who do posterior approach advise to limit flexion beyond 90 degrees and twisting of the body, and preferably lying on the back. So usually that time frame is between 4 to 6 weeks. Your surgeon may well turn around and say you can do a bit sooner, but that would be an individual decision between the surgeon and the patient.
Thank you. Is there a lower age for limit for surgery? I guess if you cover that off for hip and knee, this person is 57.
So when I started training, it was 70% of operations, hip replacement surgery was for osteoarthritis, and about 30% of patients were rheumatoid arthritis. And obviously, with rheumatoid, their joints can get degraded much, much sooner and at an earlier age. So we have done joint replacements from patients in their 30s. Sometimes you can get as teenagers arthritis, juvenile arthritis. So there have been patients who have been quite young who have had the joint replacements. The problem is not the fact that you can or you can't have. The concerns are that the hip replacement or the knee replacement may not last as long as in somebody when you are doing it, say in a person who is around 75, 80. The level of activity, the expectations, the what people want to do at when they are 45, 50, their activities and their ability to engage in physical activity and reserves are far more, and therefore they can push themselves to do things that you wouldn't expect most of the people in their 75 or 80 years to push across. So that is the concern, that when you do it in a person who is after late 60s, 70s, hopefully it will, if it works well and everything goes well, it will last for them for their lifetime. But that will not be true in a younger person. And also, if they push and do a lot more and become, go on and do impact stuff and things like that, they may wear out their joint replacements far, far, far more sooner, and therefore may end up requiring revision surgery and things, and may cause more damage to tissues. There may be a situation we have seen in patients where we can't go back and do any more surgery on patients and may end up in a wheelchair. So those are the sort of scenarios and that's why surgeons are reluctant to, advise younger patients to have joint replacements. But so long as people understand and it is individualized, and they understand and are look after their joint replacements, then 50s, late 50s is sometimes necessary to do a hip replacement. Otherwise, they can't cope. Yeah.
Thank you. I guess related to that, are there any limitations of activities of a knee replacement?
Again, when you say limitations to activities, one would expect that you are talking that normal day-to-day activities, normal climbing stairs and things like that, getting in and out of car, driving car, and playing golf, doubles tennis, and things like that. That is all okay. But if you keep pushing it and people want to run marathons and things like that, then that is probably not the best use of an artificial joint. So there are people who have done that. There are people who have gone and done things, but most likely they will end up paying for it afterwards with the wearing of the joint. So that is the reason why it is important to look after your joint and be reasonable about what you want to do with it.
Yeah, that makes sense. Thank you. And Nicholas Peake, Sorry, Nicholas says, is there a general stage of knee deterioration due to osteoarthritis? And do you recommend the replacement is considered, or is it dependent on impact on the patient's life?
So the first and foremost thing would be that um, the arthritis is severe enough that when we say we are going to replace the bone, the bone has to have significant damage on the surface, and it should be bone on bone arthritis. If it isn't, then replacing may not actually work for you because the pain is something caused by something else. So that is the most important first point, that the level of the severity of arthritis is significant. Then the next thing will be the level of symptoms, and the third thing will be how effective has non-operative treatment been. And if people can manage with their arthritis and the level of symptoms do not bother them, then even if it is bone on bone, it would be worthwhile carrying on uh, with your own knee, because body still has healing potential. Bone and joint tissue can heal itself even though with scar tissue, and people can still perform to a good level. And if they are doing that, replacing means that you're replaced with metal and plastic. That does not have healing potential, and it will the cycle goes only one way. It will gradually wear out, wear out, wear out, wear out. So it is good to have your own knee for as long as one can manage.
Yeah. What level of bend can be achieved with replacement knee?
Um, One would expect that most people are able to bend to about 110 degrees. In some people, you see them even before surgery that they can't bend beyond a right angle. And the most important, crucial point is trying to keep that range of movement before the knee replacement, because one of the most important factors determining how much bend people can get after a joint replacement is how much bend they had before the operation. So if they did not have a bend to 90 degrees, then most people will not get a bend beyond 90 degrees after surgery. Some people do, but in most people, the pre-op range of movement determines the post-op range of movement. The second thing sometimes is how much movement is helpful or necessary for day-to-day activities comfortably. So if one can bend their knee about 95 degrees or just over, then most people are able to lead a decent and comfortable life day to day, as in sitting comfortably in a chair, getting out of a chair comfortably, getting up and down stairs, getting in and out of car. Most people can manage if they can get a bend of about 95 degrees. So that would be a minimum, trying to achieve that so that day-to-day life is not difficult.
Relating to knee replacements wearing out, this person's 61. They play golf 3 times a week and do several 5-mile walks. So would that wear it out? And
I
approximately
think
how long?
most of the joint replacements are put through millions of cycles in testing, and they are sort of withstand that level of recyclable movements. I think the important points is how much force is going to it, how much pressure is going through the knee, and those sort of things. If you are a good body weight, if you are making sure you are not doing a lot of impact on your joint, and you've got good muscle tone and strength around your joint to support your joint and reduce the stresses across it, then doing that activity shouldn't be an issue.
Relating to that, is there a maximum BMI for the operations?
So at Benenden, we are not allowed to admit any patients beyond a BMI of 40. It would be sensible to get your BMI down way below that. And my recommendation would be to get it as close to 35 or lower if you can, so that technically the operation can be done very well, and B, it usually means that the stresses on the artificial joint are fairly reasonable to give you a long, durable relief of symptoms.
Okay. We have the final two questions on total hip replacement. Will you get full flexibility, such as putting on a sock after replacement? And are you likely to lose a limb after total hip replacement?
Most people, I will go with that limb first. Most people, if it is the pain is due to pain, that certainly would be benefited by a hip replacement. Sometimes the limb could be due to weakness of the muscles. Again, with strengthening, with physiotherapy, most people find that the muscles recover strength, and they lose the limb. If the limb is associated with difference in the length of the leg, then if we are able to accommodate and adjust that and make your legs equal, then again people might be free of limbs. Sometimes hip replacements particularly are associated with a difference in the leg lengths, and occasionally might need an adjustment in the shoe to equalize the limb length and therefore make their walking normal. So there are multiple reasons why people limp, and hopefully I've explained some of the things. And in patients who are limping because of pain or because of weakness of the muscle, hopefully they will recover enough and lose their limb.
Thank you. Okay, thank you again for all your questions and for being part of this evening's session. I believe we covered all the questions, but if we haven't covered yours and you've provided your name, sorry?
Sorry, can I just interrupt you? There was one question about flexibility.
Okay.
Putting on the sock. Sorry.
Yes.
Yes, most people are able to get to their feet and put on their socks and do their foot hygiene after replacement. Sorry.
Yeah. Yeah, no, sorry. I thought you'd finished speaking. I'm so sorry. So yes, if you could just move on to the last slide. Thank you. So for joining this webinar, we're pleased to offer 50% off the value of a consultation if you book during August. This consultation can then take place in September and October. Also, a callback from your dedicated private patient advisor. You will receive an email with a recording of this session, so you can rewind back and remind yourself of information. That will also include treatment information and loyalty reward points. And also, we will update you, if you like, on future events and health news. We'd really appreciate it if you could take a moment to complete a short survey at the end of this session, as it helps us improve and tailor future webinars to your needs. And if you'd like to speak to someone to book your consultation, our private patients team is available until 8:30 this evening, and they're normally available from 8 a.m. to 6 p.m. Monday to Friday, and they'll be available 8 a.m. to 4 p.m. on Saturday. We also have upcoming webinars on a range of topics, including arthrosis injections, as mentioned earlier, cosmetic surgery, and also shoulder pain. You can sign up for these on our website. Finally, a thank you from us at Benenden Hospital for joining us. We hope to hear from you soon. Take care and goodbye. Thank you.
Thank you. Thank you, Louise, and thank you, everyone.
Thanks.